I'm Dr. P.C. Gupta, heading the Department of Vascular Endovascular Surgery, Interventional Radiology and Podiatric Surgery at Care Hospital, Banjara Hills. So today we are going to talk about a very important disease which affects mainly the elderly, though we see it in younger patients also. And to discuss with me is Dr. Vamsi Krishna, a consultant vascular endovascular surgeon with us in Care Hospitals. So, Dr. Vamsi, we'll discuss about abdominal aortic aneurysms. So, can you tell people what is an aortic aneurysm?
So, the aorta is a blood vessel which supplies throughout the body. Right from the heart, it starts as the ascending aorta. Then in the thorax, it becomes a descending aorta, and it comes to the abdomen. And from there, it divides into iliac arteries, where it supplies both the legs.
Okay.
From where it supplies.
So it is the main artery of the body.
It's the main artery of the body.
Okay.
And normal aortic diameter is from a range. Then sometimes we see in patients that the aorta becomes dilated. It becomes larger. But then once it reaches a critical size, the risk of rupture of the vessel becomes high. Then we call these dilated vessels as aortic aneurysm. It is more than 1.5 times the normal size. We start calling it as
So basically you have an artery through which blood is going, it's pulsating through, and there is obviously some tension in the wall, and that is what really leads to the blood pressure that we're able to record in people. As the artery dilates, and those of you who follow physics, you would know that with Laplace's law, the wider the diameter of the tube, the more the tension in the wall. And that is what puts these patients at risk. And we'll come to what that risk is subsequently. So, Dr. Vamsi, very often we call aortic aneurysms as silent killers. So, why do we call it a silent killer?
So, once the aortic aneurysm reaches a critical diameter, it starts dilating more, and at some point the wall becomes weak where it can rupture. And once the wall ruptures, the risk of mortality is very high, even with the best treatments available in the world.
Yeah, if it's a free rupture, a lot of people would actually not reach the hospital. It would be a sudden death. And of those who actually reach the hospital and are able to undergo surgery, I think we would still lose more than 50% of them, and able to save 50% of them, and that too with a very prolonged hospital course. So how do we diagnose aortic aneurysm? Or what are these? Let's say, since it's silent, what can patients look out for? And if they find something, then how would we diagnose this?
So most of the aneurysms are silent till they are diagnosed, and even if they are diagnosed, most of them are maybe we can follow them up with ultrasound. So the ultrasound scanning can pick up these aneurysms even at an early stage. So some countries, they have this protocol for routine scanning of the abdominal aorta in elderly patients.
So screening programs.
Screening programs is one thing which you can do to screen for aortic aneurysms.
Yeah. So sometimes, and especially for thin people, if you suddenly feel a sort of pulsation in the abdomen, like it goes up and down, that could be an aneurysm. I think it's time to get an ultrasound.
Sure.
And we also see patients who have ultrasound for other problems, for kidney problem, some prostate problem.
So most of our patients in India are diagnosed because they get an ultrasound for some other problem.
Yeah. So ultrasound seems to be a very good screening test to pick up this problem. And of course, if we decide on treatment, then we get a CT aortogram to more accurately image the aorta and plan treatment. Now, what are the treatment options available for such patients?
So once it goes to the critical diameter, we need to treat these aneurysms. So two types of options are available. One is the open classical surgical repair, which has been there for many years, and the newer option is the endovascular repair of the aneurysm. So if the patient is fit, he can tolerate the surgery, his good cardiopulmonary reserve is present, I would prefer to go for an open aortic aneurysm surgery.
Yeah, I think open aortic aneurysm surgery, while slightly riskier in the early stage when we operate, it carries a much better long-term outcome if can be performed by experienced hands.
Yes.
Stents definitely are more patient-friendly, not pocket-friendly. They are more expensive.
Yeah.
So the early results are very good. The risks are low, the mortality is low, but long-term they can have more problems. But again, what we have seen in our practice, we've had very few problems even with stents because we follow what we call the IFUs or instructions for use. So we don't compromise on the quality. So if a patient is not suitable for stent, we would not put a stent come what may. We would go ahead with open surgery.
Yeah.
So only if we think that patient can have a stent which can be stable in the long term is when we would do it.
Finally, I think the outcomes depend on the IFUs.
Yeah, extremely important to follow IFUs. So once we've, let's say, done open surgery, or we put a stent graft, what we call endovascular aneurysm repair or EVAR, how do we follow up these patients?
So once we follow up these patients for an endovascular repair, we follow up them with a CT scan at the end of a month to see for the leaks. And yearly, every 3 to 6 months, we can follow up with an ultrasound. And yearly also, we can follow up with ultrasound. And if needed, we can go for a CT scan.
So standard recommendations are to keep doing a CT scan every year, but I think it involves a lot of radiation, a lot of expense, and then the contrast being injected in these elderly people, which can damage the kidney. So we prefer to follow with ultrasound and do a CT scan only if we find a problem.
Yeah. And ultrasound with an experienced hand, I think it's a better modality.
I think it's very good.
Yeah, it's to pick up the problems.
Yeah. And who are the people who are at risk for developing aortic aneurysms? Who should watch out for it?
So, elderly people, patients with cardiovascular diseases, cardiac diseases, hypertensives. These are the patients who smokers. These are the patients who are at a higher risk of developing an aneurysm.
Yeah, I think smoking is a very important risk factor. And sometimes they may run in the families also. And I think that is another group that we need to watch out for, especially if the parents have had an aortic aneurysm, been treated for that. The children also need to be followed up in the long run in their 50s, 60s. One thing unique that we see is while most patients, and even when I was training in Japan, we used to see a lot of patients in their 70s and 80s with aortic aneurysms. But here we see patients in their 40s, 50s and 60s coming for surgery. And it becomes important because a lot of these patients would actually merit open surgery and not stent grafts.
So these younger patients, they have a very long life to go.
Yeah.
So following up an endovascular repair for these years, the entire life is quite costly, and not just costly, even it involves a lot of radiation, a lot of contrast. So it's preferable that younger patients get
it's a much more stable repair. So why not offer something very stable to people who are young, and so that they have good long-term outcomes. So aortic aneurysm is a disease which can be treated very, very safely. So and I think one thing that we did not mention was the critical size. So we talk about 5.5 centimeters. If the diameter crosses beyond that, because as the size increases, we spoke about Laplace's law, as the size increases, the risk of rupture keeps going up. So we should operate when the aneurysm touches around 5.5. And if detected in time, these patients can be treated very comfortably and have a good long-term outcome. Thank you for listening to us.